And I thank all my teachers, Professor A. Srinivasan, Professor Natarajan sir, and all the senior colleagues, my senior professors, my friends, to join with me on this day on a meeting, a brief meeting on stroke. So my topic is on cranial and cervical artery dissection, approach and management. Separation of the arterial wall layers results in dissection. All of us know that. I will start with some basic, then I'll go into the details. A false lumen arises in the space where blood seeps into the vessel wall. Hemorrhage may be due to an intimal tear, or it may result from rupture or other pathology in the vasa vasorum, because we'll be wondering where the blood clot comes from. So it can be due to the rupture or other pathology in the vasa vasorum. So if you take the subintimal dissections, it causes luminal stenosis or occlusion. So if there is subintimal, we know the layer of the blood vessel wall. If there is subintimal dissection, it causes luminal stenosis or occlusion. And subadventitial dissections largely result in dissecting aneurysm formation. False lumen extension back into the true lumen can form a double channel for blood flow in the artery. And we know about it. So subintimal dissection, subadventitial dissection, and false lumen. So if you take the site of dissections, extracranial carotid dissection typically occur 2 centimeter or more beyond the carotid bifurcation, near or adjacent to the level of the skull base. So that's a common site of extracranial carotid dissection. If you take the intracranial carotid dissection, they are more frequent in the supraclinoid segment of the blood vessel. Vertebral artery dissection most often occurs in the cervical transverse process of C6 to C2. It is called as V2 segment. So from C2 to C6, that segment, the vertebral dissection commonly happens. Or the extracranial segment between the transverse process of C2 and the foramen magnum at the base of the skull. This is other site, that is V3 segment. Multiple simultaneous cervicocephalic dissections are found in 13 to 22% of the cases. Females are more often affected than males. 3 or more dissections occur in approximately 2% of the cases. So we should not be surprised we see more dissections in the blood vessel. It happens in 2% of the cases. Multiple simultaneous dissections are not typically associated with a known underlying predisposing factor, predisposition to dissection. So we may not be able to find any specific reason, even in the case of multiple simultaneous dissections. Most cases may be due to transient vasculopathy following minor trauma or infection with ischemia manifest in only one of the downstream of the arterial territories. In a case control study, superficial temporal artery specimens obtained by biopsy or autopsy from 14 patients with a spontaneous cervical artery dissection showed pathologic changes involving mainly the adventitial and medial layers. So they cannot take the biopsy from the affected vessel, the main vessel. So they have taken the superficial temporal artery biopsy and they found the pathological changes. With the vacuolar degeneration and fissuring along with capillary neoangiogenesis and microscopic erythrocyte extravasation into the connective tissue. So you see this kind of changes in the, they found the changes in the biopsy superficial temporal artery specimen. One of the 9 control arteries obtained from accident victims showed pathologic changes in the outer arterial wall. So you don't see the dissection phenomenon in the outer arterial wall, except in some of the cases of the accident victim, because the trauma can produce any kind of dissection. High prevalence of ultrastructural connective tissue abnormalities in patients with apparently sporadic cervicocephalic artery dissection. So if there is a sporadic case, there is no family history of dissection, they found some connective tissue abnormalities in patients, even without there is a history of any specific connective tissue disease. The development of intramural hematoma with subintimal dissections causes luminal stenosis or occlusion. So there is a dissection. Already there is a double lumen, and there is hematoma happens, intramural hematoma. It further occludes the blood vessel. This may result in cerebral ischemia due to thromboembolism, hypoperfusion, or a combination of both. Thromboembolism rather than hypoperfusion is considered the major cause of ischemic symptoms. We don't need, not necessarily due to hypoperfusion, that is not a common cause. Thromboembolism is the commonest cause of ischemic episode in patients with dissection. Subadventitial dissections with aneurysm or hematoma formation and vessel dilatation may cause local symptoms from compression of adjacent nerves and their feeding vessels. So the vessel, what happened if there is a dissection, there is intramural hematoma, there is expansion of the vessel, and that compresses the surrounding structures, which results in pain, partial oculosympathetic paresis like Horner syndrome, lower cranial neuropathies, or cervical nerve root involvement. Minority of cases, dissection of intracranial arteries which lack an external elastic lamina and have only a thin adventitial layers can lead to vessel rupture with the subarachnoid hemorrhage. So in intracranial artery dissection, you can see subarachnoid hemorrhage as a presentation of the dissection, and the adventitial layer is very thin in intracranial vessels. So that can lead to a vessel rupture if there is a dissection. Most dissections occur spontaneously or after minor or trivial injury. Mild or trivial trauma in 40% of cases, basketball, childbirth, chiropractic neck manipulation, coughing or sneezing, dancing, minor sport injuries, roller coaster or amusement park rides, scuba diving, skating, swimming, tennis, trampoline use, vigorous exercise, volleyball playing, weightlifting, and occasionally yoga. All these things can produce dissection. Common association is fibromuscular dysplasia, which accounts for 15 to 40% of all cases of cervicocephalic dissection. Series of 1,934 patients with cervical artery dissection identified only 6 with inherited connective tissue disease, that is less than 1%. It is not like as commonly believed these patients should have underlying connective tissue disease. But the data, what I told, they found it is less than 1% of patients has inherited connective tissue disease. Although Marfan syndrome is a known cause of aortic dissection, only few cases of isolated cervicocephalic dissection have been reported. Population-based study from Minnesota, they found spontaneous internal carotid artery dissection happens in 1.72 per 1 lakh population. Spontaneous vertebral artery dissection happens in 0.97 per 1 lakh population. Combined annual incidence of both carotid and vertebral happens in 2.6 per 1 lakh population. There is no clear deletion. Dissection is common in winter. The reason is not known. Extracranial dissection is more common than intracranial dissection in North America and Europe. Intracranial dissection is more common in Asian population and in children. For patients without ischemia, at the time of diagnosis, risk of ischemic stroke is limited to the first 2 weeks after the diagnosis of cervical artery dissection. There are times we have seen people coming with neck pain, some other findings, and they don't have ischemic manifestation. And then you suspect and diagnose there is a dissection. If they escape for the coming 2 weeks' time, then the chance of getting stroke is little less. Head and neck pain happens in 57 to 90% of the patients. So when there is a head pain, neck pain after trauma or some kind of exercise, which I mentioned before, we have to suspect cervical artery dissection. We have to do investigations for that. Neck pain may be more frequent with vertebral artery dissection compared to carotid artery dissection. There are patients come with neck pain, occipital pain, sudden onset after some kind of chiropractic or some other procedures. They may get neck pain more frequent with the vertebral artery dissections, more common with vertebral artery rather than carotid artery dissection. Headache is ipsilateral to the dissection. So if you see if the patient complain of headache, could you turn off the mics, other mics? Headache is ipsilateral to the dissection. Temporal region, the patient complain of temporal region pain, it is usually happens in carotid artery dissection. Occipital region, vertebral artery dissection. Finally, could you put off the mics, other mics? Ravichandran, could you put off other mics? Occipital region, vertebral artery dissection. The headache can be migrainous nature, cluster headache like flap headache, isolated monocular or Horner syndrome in 25% of the cases is partial. Cranial or cervical neuropathy, single or multiple cranial neuropathy in 12% of the cases. 12th nerve commonly affected, then 9th nerve, 3rd, 5th, and 6th is less common in carotid artery dissection. So as I was telling, there is a dissection, there is a luminal expansion, double lumen, intramural hematoma. When the expansion of the artery happens, it compresses the surrounding nerves. Cervical root involvement rarely in vertebral artery dissection. So the patient can have cervical root involvement in vertebral artery dissection. It can occur without associated ischemia. It's very, very important. Patient don't need to have stroke presentation, or patient don't need to have TIA in dissection. When there is a trauma history, there is a neck pain, there is a headache, we have to exclude a dissection happen to the patient or not. Pulsatile tinnitus can occur in isolation. Cervical artery and ischemic stroke patient study, it's called CADISP study, of 778 patients with cervical artery dissection. They found pulsatile tinnitus in 8% of the patients. Ischemic stroke or TIA happens in 67% of the patients with craniocervical dissection. In 2012, systematic review of 75 studies that described 1,900 patients with vertebral artery dissection, dizziness and vertigo was the most common presentation. It is not certain that whether ischemia is the cause in all cases. There are times you don't have any posterior circulatory stroke presentation. They can have only dizziness and vertigo and neck pain, as I was telling initially, and it can be the presenting manifestation of the vertebral artery dissection. In 2015 systematic review of retrospective case series, subarachnoid hemorrhage was associated with intracranial artery dissection in 8 to 69% of the cases. So it's quite large range actually, but you can see a subarachnoid, as I was telling, that hemorrhage, because there is the outer layer is very thin in the intracranial blood vessels. In rare cases of subarachnoid hemorrhage is found in combination with ischemic stroke. So in sometimes, very occasionally, rarely, you can say a combination of ischemic stroke and subarachnoid hemorrhage. With the neck pain and headache and this kind of presentation, history of trauma, we have to keep in mind this patient may be having a dissection as the cause. If you take the neuroimaging study, MRI standard T1, T2 weighted image, flare and diffusion weighted sequence we have to do. Cervical cranial T1 fat saturation imaging is useful in identifying small intramural hemorrhages. MRA of the head and neck should be obtained with contrast enhanced and time of flight MR angiogram. So that gives a clue that the patient is having a dissection. Very sensitive. It will pick up quite large, almost it will pick up most of the dissection happening. Non-contrast state CT, you have to do a non-contrast state CT and CT angiogram of the head and neck vessels. That gives also a equal result like a MR angiogram. Axial source images and three-dimensional reconstructions are useful for detecting dissection. Intimal tears and medial or subendothelial hemorrhage can be picked up in this imaging. Use of conventional angiograph for patients when clinical suspicion for dissection remains high despite negative non-invasive imaging. So there is no need for routine conventional angiogram, but if there is a clinical suspicion is very high, and even though the MRE and CTA sensitivity is quite good, if you are not picking, it's not picking up, or maybe missed in a few cases, then you have to go for a conventional angiogram. This is the international recommendation. It all more individualistic actually. So carotid duplex and transcranial Doppler, if you do a screening, and it can be used for monitoring the progress and how it is evolving over a period of time, or whether it is healing over a long period of monitoring. But it detects only 68 to 95% of the patients. So we should not do only carotid duplex and CTs. We say the patient don't have dissection. The clinical history, clinical suspicion is very, very interesting and very, very important. And we have to do appropriate investigation to pick up these dissections. So the important findings are, you can see elongated tapered stenosis. So you see a blood vessel, then the tapered stenosis in 48% of the patients, a tapered occlusion in 35% of the patients, and dissecting aneurysm. You can get a pseudo aneurysm because of dissection, the outer wall bulges out in 17% of the cases. In European study, MRI finding in vertebral artery dissection, intramural hematoma is seen in 91% of 157 cases. So you have to look for intramural hematoma. So this test can pick up this elongated tapered stenosis, tapered occlusion, dissecting aneurysm, intramural hematoma. I think many would have seen in the, because all of you have seen the sting sign that you see because of dissection, sting sign in the vessel, tapered stenosis or occlusion of, or flame-shaped occlusion. If there is occlusion, then the remaining vessel seen as a thin stream. It can look like a flame. So this is called flame-shaped occlusion. Intimal flap, you can see a flap inside the vessel. Dissecting aneurysm, you can see the aneurysm itself. And the intramural hematoma, you can see a crescent sign. If you do axial sections, you can see there is a crescent sign and in the blood vessel lumen and distal pouch. So almost I'm finishing the talk. If you come to the treatment, for patients with cervicocephalic dissection who present with a transient ischemic attack, or acute ischemic stroke, the standard approaches to stroke management should be rigorously followed. So sometimes you see acute stroke in the emergency in the window period, and you don't know that whether dissection has the cause. Patient may not be able to tell all the story. The attenders may not also know. So you have to approach the patient like a regular ischemic stroke. Like whether you want to thrombolize, if there is ischemia evolving, I think the protocol is more or less same in the window period time. Beyond the hyperacute period, antithrombotic therapy with either anticoagulation or antiplatelet therapy. So there are people who divide on this, and people have found both are equally effective. The limited available evidence suggests that there are no differences in efficacy between anticoagulation and antiplatelet treatment for preventing ischemic stroke in patients with extracranial dissection. Very important point. Although it is likely that anticoagulation is associated with a higher risk of hemorrhagic events. For intracranial dissection suggestion, so if there is intracranial dissection, antiplatelet therapy is a drug of choice. There is no subarachnoid bleed. Intracranial dissection, grade 2C evidence that antiplatelet therapy is a drug of choice. For patients with non-ischemic local symptoms caused by extracranial cervical dissection, antiplatelet therapy for prevention of ischemic stroke in grade 2C. As I was telling that not necessarily all the patients with the dissection will have a stroke manifestation. They don't need to have stroke manifestation. They can have neck pain, and they can have temporal headache in carotid dissection, occipital headache in vertebral artery dissection. They can have cranial nerve manifestation. They can have cervical root manifestation. They can have orbital pain. All those things that you suspect and pick up the dissection. Patient don't have ischemic manifestation. The drug of choice is antiplatelet therapy, grade 2C evidence. And they classifying, there is ABCD criteria, low risk TIA and high risk TIA based on the score, more than 4, less than 4. It is like that patient has ischemic manifestation, then you see all the findings, and the patient, depending upon the severity of the dissection, all those things. So if there is a low risk of TIA, the patient needs single antiplatelet therapy. The patient is having high risk of TIA, they need a dual antiplatelet therapy. So it's very, very clear that acute ischemic episode, window period, treat like a regular stroke patients, and the patients have a manifestation or not, then you have to give antiplatelet therapy. If you pick up the dissection, so low risk TIA, single antiplatelet, high risk TIA, dual antiplatelet. There are groups favor anticoagulation, there are group favor antiplatelet therapy. Both are equally effective. It all depends upon the individual experience. And I think that antiplatelet is commonly used, and the anticoagulation also equally used by a separate group, and they feel equally effective. Only thing is, if you feel there is high risk of bleed, then you can go for antiplatelet itself. Thank you very much.